Thank you all very much for coming out on this very brisk evening. Good evening and welcome. I'm Nirav King. I'm the Vice President for Programs here at the Chicago Council on Global Affairs. Tonight's program is on the record, so we'd encourage you to use social media. All the Twitter handles are on the bios on your chair, but please silence your phones. We've had some interruptions lately when people have forgotten, so just switch the button down. Tonight, we'd like to thank our sponsor, AbbVie. They're a wonderful supporter of the Council. Jeff Richardson will be up in a moment to do the introductions. He and Tracy Haas have been just complete champions of our work, and we're so grateful to them for all their support. As I said to Jeff when he contacted us about this panel, that a lot of the public in Chicago really turned to the Council to move away from the media hype that surrounds these kind of issues, and so we're very grateful for their support, and of course to all our panelists. Thank you also to our partners, AmeriCares and C2ST. Alan Schriesheim, their chairman, is here tonight. Thank you, Alan, for your support. A few upcoming programs before the holiday chaos begins. Tomorrow night, we'll welcome Min Shin Pei, who will talk about Beijing drama, a very interesting time to be hearing from one of the top scholars on China. December 2nd, we're delighted to welcome back Walter Isaacson on The Innovators, his new book. That's always a great program. And then on December 4th, another panel that should be rather elucidating will be on the rise of ISIS or IS or Daesh, whatever you care to call it, in the Levant. I'll be back up to moderate the Q&A, but please now would you join me in welcoming to the stage the Vice President of the AbbVie Foundation, Mr. Jeff Richardson. Thank you.
Good evening, ladies and gentlemen. AbbVie is delighted to be the sponsor of this really what I think promises to be a very exciting panel. I always try to say a few words just briefly about the people that are actually doing the work and doing the work on the ground. We have so many partners doing so many interesting things in different areas, but I just want to specifically call out our partners doing work in Ebola. We're funding efforts right now in West Africa with AmeriCares, Direct Relief, International Medical Corps, MAP International, and Partners in Health. So I just want to thank them specifically for their outstanding work. I also want to acknowledge some of my AbbVie colleagues who are here tonight, and I hope that you have a chance to meet them. And it's a great to have you here. Thank you so much. The current Ebola outbreak has claimed thousands of lives and has been declared a public health emergency of international concern by the World Health Organization. While isolated Ebola epidemics have occurred in the past, the current outbreak spread across the borders to Guinea, Liberia, Sierra Leone, and beyond West Africa, and as you know, even here in the US and Europe, albeit a few cases, but nonetheless very dramatic. What explains the virulence of this particular outbreak, and what lessons are governments, NGOs, and doctors learning from this crisis to help them prepare for the next one? This evening, we are fortunate to have with us a group of experts, each of whom brings a unique perspective to these complex issues. To introduce them, let me turn it over to our moderator for this evening, Judith Munson. But first, let me just say a few things about Judy. Judy is an attorney who has worked in public health at the local, state, federal, and international levels, including as a senior consultant at the Centers for Disease Control. She now teaches a course at Public Health Emergency Law at the John Marshall Law School and at the Masaryk University in the Czech Republic. Please join me in welcoming Judy and our panel. Thank you.
Thank you. Thank you very much, Jeff. That was very nice and accurate about the gratitude that we express to those who are actually being funded and going and doing the work. I would like for you to know that I just took a quick look at the statistics right before I came, and just to round them off, I would tell you that there are 15,000 cases of Ebola now. And about 1/3 of them have resulted in deaths, and about two-thirds of them have been confirmed. So we have a crisis on our hands of enormous proportions. We are grateful for our panelists tonight because we have an array of experts that has been assembled and from which we will learn so much. Let me just mention them to you. We have a not-for-profit representative, we have a doctor, we have a lawyer who is also a doctor, and we have a businesswoman. So we have the whole landscape covered. Let me say that I'm going to introduce them all now, just briefly, so that you will know who they are. But first, let me say that we have Michael Nyenhuis. He is the President and Chief Executive Officer of AmeriCares, where he leads the global health and emergency response organization that increases access to care in more than 90 countries. He has oversight of offices in the US, El Salvador, Haiti, India, Japan, and the Philippines. Dr. Sola Olopade is the professor of medicine and a clinical director of the Center for Global Health at the University of Chicago. His research focuses on the relationship between environmental and genetic factors and how they affect pulmonary diseases, particularly in developing countries. Nirav Shah is an emerging leader here at the Chicago Council on Global Affairs, and he practices in the global life sciences at the law firm Sidley in Austin. He is also a lecturer at the Department of Medicine at the University of Chicago, where he teaches courses in global public health and mathematical epidemiology. Nancy Green, the Executive Vice President of Strategic Account Management at Aon Risk Solutions and leader of Aon's Ebola Response Task Force. She is also the thought leader for Aon's approach to Black Swan events response and preparation consulting. Won't you join me in welcoming our panel? And now we're going to get started, and we're going to just have this informally prepared. We have some prepared questions. We're going to direct them to one of the panelists, and then we will see if there are others who would like to comment on that particular subject. The first one, Michael, I would like to direct it to you. It is, what are the causes of the outbreak?
Sure, and as I address that, maybe I'll just give you a little bit of context for the work that we're doing there, which anchors a little bit of maybe my perspective of the causes there. As a global health and disaster response agency, we've been engaged in West Africa for years, and in Liberia in particular, among those three countries. And back in April, we had some communication from one of our partner hospitals. This is a hospital we've worked with for a long time, providing medicines and supplies and doing other work with them. Hospital in Liberia that said they had some initial cases of Ebola. So this is early April. And they asked if we could help. So we actually provided them a grant right away so that they could buy locally personal protective equipment for the health workers that were there and some other supplies. And from that moment, it's just snowballed. And to today, working in all three countries, we've provided over 4 million units of personal protective equipment, IV fluids, medicines that are needed for patients there, done a lot of work with local health workers. In addition to that, we've recruited a medical team from the US that's serving in one of the Ebola treatment units. And we're also beginning now to look at what are some of the long-term solutions to this in terms of improving the health system there. And that's where I'm going to anchor back into your question about the health system there. One of the problems that these countries have is they do not have a well-functioning health system, and that makes it a place that's just ripe for an epidemic to come. If you look at the context of the three countries, it's not really a surprise, right? These are countries, Liberia and Sierra Leone, that were in civil war for 10 to 15 years, ending maybe 10 years ago, and for the past 10 years they've been trying to emerge out of that. Guinea was strongly affected by both of those civil wars because it became a place where a lot of refugees went. So it was a difficult time for that country as well. So you're talking about three countries that are fragile to begin with. They have they rank among toward the bottom of the Human Development Index statistics. They have among the world's highest maternal mortality rates and infant mortality rates, which are the classic public health indicators. So they're just fragile countries to start with and have very poor health systems. Compounding that, when you get out into the rural areas, which is where this epidemic started in rural Guinea and then spreading into rural Sierra Leone and Liberia, the health systems are even less existent there. Maybe in the capital cities you have a number of doctors and you've got a functioning hospital, but Liberia has one doctor for, before the epidemic, one doctor for about every 100,000 people. And most of them are concentrated in the capital city. So you get out further and they just aren't there. So you have not enough health workers. You've got, under-resourced, very under-resourced clinics and health centers. You have doctors and nurses who are not very well trained. They're confronted with an epidemic they don't know about. They don't have the personal protective equipment that they need. And the chance for it to move fast is there. So really, the reason those three countries are so vulnerable have a lot to do with their history and the current state of their medical practice.
Thank you very much. I'm wondering, Dr. Olopade, I believe you have just returned from Nigeria, and possibly you have seen yourself what has been going on there. Maybe you would like to comment on this question.
Well, I want to thank the Council for asking me to be on this panel. I'm happy to be here. And, before talking about, Nigeria, I'm originally from Nigeria, but I've lived in Chicago for 30 years, and we had a meeting planned for Nigeria middle of August, so it would be difficult for me not to go back home and do some of the work that I do. Some of my research work is intentionally in Nigeria. But when you look at Nigeria and some of these other countries like Guinea, Sierra Leone, and Liberia, there's a stark difference in terms of the economy and the wealth. Because sadly, the problem with Ebola is we're dealing with a perfect storm. When you look at a war-torn country, when you look at poverty, you look at those rural areas where they don't actually have water or sanitation, they don't have any healthcare infrastructure, and then there's overcrowding, and you superimpose cultural practices that promote the spread of diseases like Ebola. It was really a disaster in the making. And to just put it in context, Ebola has been around for over 30 years. Usually it involves rural areas. People die in the rural areas, and it's a lot easier to contain. But when you break into a very populated area with no access to any infrastructure, and the initial doctors are dead, you can see why everybody is worried. So when we got into Nigeria, clearly because they have a lot of resources, there were people at the airport with infrared thermometers already checking people's temperature, before coming in, even though I was coming in from the U.S. But what was striking was that it wasn't really only a government effort, because if you were going out to some of the restaurants had infrared thermometers, and people mounting the restaurants. You had access to water, hand sanitizers, also in the banks. And what was most important to me to see was the level of education of the people, because they used social media very effectively, texting people, clarifying what Ebola was and what it wasn't. And it's a little different from what we see on TV here, where a lot of the media is actually geared towards scaring people. So people, regular people on the streets, had text messages, even when there were misunderstanding about Ebola, because at the early stages, people were told they needed to take baths with salt or drink a lot of salt. So there was effort immediately to go to the texting to, redirect that effort. And the government was actually very open and transparent, informing people every day the nature of the epidemic and where they were. So it's really a problem of resources, and I'm hoping that what the Ebola problem will allow us to do is focus on a more long-lasting and sustainable solution to this problem, because it's not about Ebola alone, it's about the health systems in a lot of these developing countries in Africa. It's not only Liberia. There are most of the countries on that continent don't have good health infrastructure, and we are going to continue to be at risk if we don't actually invest at a time, which is now, to partner in terms of developing infrastructure, because it costs a lot more money to get the military to fly in there. It's cheaper to put in water, toilets, sanitation, and health systems. So I'll stop there. But the success in Nigeria was very predictable because it's the biggest economy in Africa. They had people who could relate to this. And more importantly, just one quickly, they had an infrastructure, a surveillance system that was actually developed to eradicate the last few pockets of polio. So it was a lot easier for them to also activate that incident command system. So it was really good public health at its best, and I think they got lucky too.
Thank you very much. It was the first country to be declared Ebola-free, right, in October. Yes, thank you very much. Does anybody else? Michael, do you have a comment you'd like to make about that?
No, only that we've seen the success in Nigeria and in Senegal as well, but there's concern now about Mali, and I think we need to pay close attention to that. I don't think we really know yet whether or not there are enough cases there to cause concern, or whether it will be another success story. So that's one of the places we need to keep a close eye on.
Maybe they're listening to what Dr. Olopade had to say. Thank you. Thank you very much. I would like to turn to Nirav.
Judy,
Yes?
I just have one thing that I wanted to add on the comments that these two gentlemen made. You know, one of the other things that I think has also been influential has been, particularly in an area like Liberia, where you mentioned the infrastructure had been impacted by the civil war there. The lack of access to electricity through the electrical grid, I think less than 2% have access to the electrical grid there. That was a statistic I saw recently. I don't know if that's necessarily the most up-to-date one. And as well, in order to get to some of the rural areas, some of the roads, I think that only 7% of the roads are paved in Liberia. So you recognize some of these logistical challenges in addition to some of the healthcare infrastructure, and you start to see that some strategies that work in some of the other countries might have a little bit more challenge. And when I think we get to some of our other comments today, we'll be talking a little bit about, you know, creating nuanced responses that recognize some of the unique characteristics of the different countries affected. So,
Thank you.
Yeah.
Excellent. Thank you. I would like to turn to Nirav, our representative from the legal arena. What is the regulatory framework for such health crises as we are facing right now in West Africa?
Sure. Well, there are many ways to think about this. First of all, thank you to the Council for inviting us and convening this panel. Obviously a very timely and important topic. To those of you who were at a talk I gave on this issue last week, you know I've been thinking a lot about Ebola. It's now my second favorite infectious disease, so it's something that's been occupying a lot of my mind. With respect to the regulatory aspects, probably the classical ones focus on issues like the regulatory incentives that are necessary to foster and create incentives for drug and vaccine development. We all know that's an issue. It's something that's been in the press a lot. I submit that there's a lot more to it than meets the eye. I mean, the classical way to think about this is what can we do to foster more drugs and vaccines? And the comment that's also attached to that is that, my gosh, isn't it terrible that we've had a vaccine sitting on the shelf in Canada for 10 years and no one having done anything with it to bring it to market? And wow, gosh, why are we just now hearing about all these candidate drugs that have been sitting around with no one actually doing anything to put them out there? Well, as everyone knows, commercializing a drug is exceedingly difficult and costly. Current estimates range from anywhere from $1.2 to $1.5 billion to get a drug to market. The same goes for vaccines. And so while it's necessary to have clearly delineated regulatory pathways for emerging diseases, it's probably a bit facile to blame, if you will, any drug developer out there for not taking a vaccine or a candidate drug all the way to market. To think about it a different way, for those who do believe that there was some foot fault in not bringing these drugs and vaccines to market, I suppose my question back would be, what's your theory of drug development then? There are lots of candidate drugs and vaccines out there. Should we also go all the way with one for Lassa fever, which is number 4 on my favorite diseases? Should we take the one for dengue fever all the way? What about Japanese encephalitis? We have a vaccine. Should we work on getting a drug out there? It's very difficult to do drug development when you have high magnitude but low frequency or low prevalence drugs. And that presents a very difficult regulatory conundrum. One, no matter how many economists and lawyers we get in the room, we'll probably always get the answer wrong. The other one that I would just like to bring up really quickly is what would we do even if we had the vaccine or the drug? Where would we test it, for example? There was just a big meeting on this issue at the WHO recently, and the conundrum here, the policy conundrum, is that the case fatality rate for Ebola in West Africa seems to be hovering between 70 and 90%. It's terrible, it's awful. Whereas in the United States, it's close to about 10% of people with Ebola die. That has huge policy implications for where we choose to test our drugs. It's much easier for statistical reasons to test a drug or a vaccine in a place where 90% of the people die without it. It's very easy to have a smaller study that shows a statistically significant difference. Yet testing a drug or vaccine in those situations, in those circumstances in West Africa, is fraught with ethical concerns, as I'm sure everyone can appreciate. So that yet is another policy conundrum that, sad to say, the folks at the WHO quite yet have not worked out. The last one that I'll leave everyone with is really rooted in domestic issues, and that is to say, why have the responses to Ebola in the US been so flat-footed? Why is it so common for folks to criticize the responses of various state governments and Dr. Frieden at the CDC? There are lots of reasons. We don't have to get into all of them, but the one that I'd like to ask everyone to think about is the problem of triggering costs. With things like disease outbreaks, the costs that you or we as a society and a government incur accrue from the second we flip the switch. So the second that we decide to say we are activating our emergency response system to deal with Ebola, we accrue all of those costs on day one. We mobilize our entire public health force, we deploy all of the personal protective equipment, we send the vaccines out in the field. And that's great, but if we're wrong, right, if what we've seen is actually a false positive, and the epidemic doesn't actually materialize, we have sacrificed great human and financial costs at spending money on something that didn't materialize, and what we've also done is weaken the trust in the public healthcare system for the next outbreak. So those are 3 regulatory and policy issues that I'd ask everyone to think about.
Thank you very much. Thank you. Does anyone else have a comment?
Just maybe a comment on the vaccine. This is it was a lot of conversation about the vaccine, and I don't want to at all dismiss the power of vaccines. But in this case, Ebola, because it is actually fairly difficult to transmit, and the public health measures that can be taken to stop that transmission are pretty strong if you have a functioning health system, that the idea of deploying a vaccine widely to a disease that has not had very many cases really over the course of its history seems like a lot of costs and a lot of mobilization to be able to do that, when it'd be much more cost effective just to mobilize education around it and to prepare the health workers for it and to deal with it in sort of a classic public health way rather than through a vaccine.
I think that's entirely right. Ebola is this fascinating public health conundrum and PR conundrum because it's outrageously infective but not very contagious, which is to say my likelihood of getting Ebola if I encounter someone with Ebola and engage in the various behaviors where Ebola is transmissible, right? We mix bodily fluids because I'm taking care of a patient who's vomiting. Highly infectious in those circumstances, but actually as an epidemiologic matter, not very contagious. And so not clear that a vaccine is the right public health strategy here.
I would like to just make a few comments regarding clinical trials and drug development. And I'll start with globalization. In the past, it was easy to just look at problems like Ebola or a lot of what we would call neglected tropical diseases. They used to be diseases that we thought were out there. But with globalization and ease of travel, it's very, very easy. If it's not Ebola, it could be MERS, it could be SARS, it could be dengue, it could be chikungunya, all of these diseases that we don't usually see here. And everybody is here tonight because you look at what's happened in the last month. Everybody is scared because Ebola got here. And until we start looking at a way to change the approach that we look at the world, will continue to be at risk. In fact, 55% of clinical drug development and trials are actually going globally because it's a lot cheaper. Some of those places don't have good regulatory systems. So we're actually going there to exploit and develop those drugs without the intentions of marketing them there. So we can either have an approach where we're looking at a pro-business perspective just to make money, or ask ourselves, do we really have a moral imperative to care about some of these disadvantaged people? Or with the reality of Ebola, wouldn't we really be acting in our own self-interest to look for a pragmatic and a much cheaper and efficient way of investing in developing infrastructure there? I'm not saying do it alone, but develop partnerships so that those places can start taking care of their own problems without it being our own problem. Because if we think we're just going to be insulated here, close the borders, forget about those, all of those diseases are going to be here because our children, our students, more than us, are traveling globally. So what are we going to do when those students come back home or when they go and do their research work and come back with Ebola? We just have to deal with it and look for, it's not just about the economics of drug development. There's a moral imperative to be part of developing a solution that will be more sustainable. That's the way I look at it.
Thank you. Thank you very much. I would like to turn to Nancy now, and I would like to ask how business views this outbreak and this developing story that has run rampant through our, not only the population, but through our hearts and our minds.
Thank you. First, I just wanted to say thank you very much for the opportunity to come and be a part of this panel. Because I'm thrilled to listen to people who have directly contributed to what's going on in the front lines. I'm representing the business community, and I'll tell you a little bit about why I'm participating here on the panel. I head up AON's Ebola task force, and we set that task force up to support our clients. I don't know if you're familiar with AON. We're a 66,000 employee risk management, insurance, employee benefits, and reinsurance brokerage organization. We're headquartered in London, but we also have a very large presence in a lot of other countries. We're in 120 countries, and so I'm here in Chicago and kind of lead the task force. And I'm doing that because I'm in a position, I've been at AON for 27 years, I'm in a position where I have a chance to see a lot of different clients dealing with the risk of Ebola and wondering how they can address it with their employees, wondering how they can manage it with their business, and they're looking for information. So we set up our Ebola task force, and our website, that's you can find it at aon.com, we repository for information and links to the CDC and some of the other organizations that we're going to be discussing tonight. And we did that in order to provide information. And I think it's very similar to what Michael and Shola just talked about. Being global The world is so interconnected now. It's really fascinating to see how quickly things can go. And I don't know if you all remember the SARS epidemic back in 2003. They traced ground zero for the global spread, not ground zero for the first infection, but for the global spread, to the elevator button on the 9th floor of a hotel in Hong Kong. And how did they do that? They traced that because people on that floor, there was someone from Canada who went and took it to Toronto, and there were a variety of other people from other countries all on that floor, and that elevator button was one of the items that they figured most everybody on that floor had touched. So that just kind of is a stark, I think, realization that the opportunity, as Shola just talked about, to recognize that we're part of a global community, and to recognize that we have an opportunity to partner together. And I think that the opportunity to do some things here in the U.S. And Ebola just provides a really great opportunity to do that because it's getting so much attention right now, and there's definitely a need.
Thank you very much. I would like to say that you have mentioned the source of the SARS outbreak when the new vector was identified, which was the airplane, getting on the airplane and going back to the home countries where the individuals who were on the 9th floor would take the pathogen. One of the things that they wanted to identify first was where did it come from?
Yes.
When they discovered what that was, they killed all of the civet cats in Guangdong province. There were 10,000 of them in the exotic meat markets. When it came to the avian influenza outbreak in Hong Kong, what they did was they discovered that it was in the live chicken markets, and they killed all the chickens. That was in 1997. Now, right at this moment, in Europe, we have a duck farm in the UK that has just had all of its ducks culled. They call it culled, C-U-L-L-E-D, all of them killed, so that it's not going to be spreading any of the avian influenza strain that was found there throughout the kingdom. And in the Netherlands, they have just now withdrawn the prohibition on transport outside of the country for any of the poultry that has been raised in the Netherlands because of another strain of avian influenza in the chickens. And they killed all the chickens. So we have here this incredible, horrific outbreak in the human body, and we don't talk about where it came from. Maybe we could at least address that. Maybe we could find some ways that somebody could say where it's come from and what can we do about that. Does anybody?
In Congo and also in southern Sudan in 1976. And probably from, Ebola has been in a lot of the wild animals, bats, for a long, long time. But when you have too much intimate contact with some of these animals, people usually kill some of these antelopes and some of the bats as delicacies. So when you get exposed to the blood, which is the only way you can get Ebola, contact with body fluids, that was the Sentinel event a long time ago. But because it was in a rural area, it killed a lot of people at that time too. But because it was in a rural community, it was easier to do contact tracing, which is what is really needed to, stop the spread of Ebola. But 30 years later, we still haven't learned our lessons because, again, we're dealing with Ebola. But the real issue that we really need to be talking about are the developing. It's just about the health systems. And we had another opportunity many, many years ago. I'll take you back if you give me 2 more minutes. In 1978. In 1978, actually, the United Nations member countries, about 134 of them in the USSR, then decided that health was a right, and that they were going to assist all these poor countries to actually invest in developing primary healthcare systems. This was in 1978. And then in 1980, we had new leadership both here and in the UK, and we used the IMF and World Bank to develop the structural adjustment program and turn medicine into a commodity. So people who had safety net programs before, now you had to pay for services. So people stopped going to the hospitals. People were presenting late, and most people will agree that the structural adjustment program was a failure. But that opportunity to create primary health care system in 1978, we're still paying the price for not being bold at that time. And unless we actually reinitiate that effort to help and develop primary healthcare systems, we'll be in this same situation decades to come.
Well, that is our final question, is what is it that we have learned that will help us prevent future outbreaks? And I think Dr. Olopade has certainly presented his view. Do we have some other views?
One epidemiologic note. I do believe that primary healthcare systems and well-functioning healthcare systems are vitally important. There's also a very important role here for almost anthropologic education. That is to say, as Sola mentioned, one of the reservoirs that is known to be the case is the fruit bat, as well as various non-human primates. The initial transmission, the initial zoonotic transmission, seems to occur in the wild or in very, very rural areas when villagers kill those animals or push out of their villages because of a paucity of food and are forced to go out and kill those animals for food. So two immediate strategies for disease control emerge from that. One, don't let people get so poor that they have to go out and kill bats for dinner. Secondly, educate them that there are many, many other animals out there that are not known to be reservoirs for these zoonotic diseases. And those are two vitally important places to break the chain of transmission from animals to humans immediately.
Thank you. Nancy?
I kind of wanted to approach this from a little bit of a different angle, from the business angle. I mentioned that many of our clients are challenged by understanding how to advise employees, how to take a look at their operations, and work towards managing towards resilience. And so a couple of the things that I think might be interesting to sort of talk about here is, regardless of whether we're able to manage it from an epidemiology perspective, there is an opportunity for organizations to manage it from a business perspective in terms of providing information to employees. I'll just start with that. One of the things I think we've all seen is that there has been a lot of fear promoted by media reports, fear basically promoted by misinformation in some instances. And so I think employers have an opportunity to share good information with employees to de-escalate the fear factor. And then once you can start doing that, employees can also then share it with other people in their family and friends and that type of thing. But having access to good information, fact-based information, starts to take the fear and emotion down a bit, so you can start focusing on the situation. And when I'm talking about providing education to your employees as well, they need to know what the organization is doing in terms of mounting, a preparedness plan. So they understand who to talk to if they have questions, they understand where to go to get information, because right now there's information overload. Anytime there's a new development in the Ebola front, there's a lot of information going. So there's the opportunity to do that. Also, too, a few years ago, organizations prepared for pandemic. We thought pandemic flu was going to have a stronger toehold than it did. But in the process of that organization approach, they developed plans for the pandemic impacts. So what we've been trying to do is help clients understand those plans can be resurrected, but you need to be able to understand the differences between what pandemic flu characteristics are and Ebola, so that you know where to adjust those plans. So here you're starting to arm your employees and other stakeholders with information that can help them make good decisions. And there's a host of other things that can follow with that. But I think now is a good opportunity to get that education out, and employers can be a foundational part of that process.
Judy, if I could just follow on to that, just talking about the corporate response, business response to a problem like this. We're blessed to be sort of on the other side of the corporate response, which is to recognize the power of corporate philanthropy to make a big difference in an event like this. So you have numbers of companies that have come forward with donations of products and cash to make this happen. AbbVie, obviously, making a significant contribution to AmeriCares, but to other organizations as well. Companies like Baxter, that's donated to us about 50,000 bags of IV fluids, which are just essential to dealing with patients because of the dehydration that happens. Companies like Cardinal Health, that's donated just tens of thousands of gloves and gauze and gowns and boots and masks and all of that are needed to protect health workers. So as companies are thinking about internally how to deal with their own business situation, that exercising that philanthropic muscle that they have that can really make a huge difference is critical.
Thank you. Anybody else? Well, ladies and gentlemen, what I would like to do at this moment is to invite you to ask questions of our panel.
Thank you very much. That was fascinating. Now we'd like to go out to you. Please remember to wait for the mic, speak clearly into the mic, and make sure your question's a question. Yeah, the gentleman right there, please. Wait for the mic, please.
Yes. I'd like to ask the panel if these recent events concerning Ebola and the situation in the U.S., as opposed to West Africa, raise any new issues for preparedness in the U.S. with respect to healthcare institutions.
I think
Shola, since you're at the hospital,
I'll
maybe.
take that. I don't think anybody in the United States should be worried about Ebola. I mean, one thing I forgot to say was the CDC was actually in Nigeria with the WHO and Doctors Without Borders to actually set up the strategy to do the contact tracing. There was a mistake in Dallas, but it's no reason to indict CDC. We're the best at the game in terms of public health, so there's no reason for anybody to be alarmed. With respect to the hospital preparedness, I think speaking about the University of Chicago and many of the other top academic institutions, that's again no reason to be worried, because when you look at the number of cases that we've had to deal with in the US, if those cases are identified early and we're able to actually provide supportive care so that the extreme dehydration, which leads to organ failure, your kidney, your liver, if you can prevent people from being too advanced, they're not going to die from Ebola. If you look at most people who have died, especially in the US, it's from late diagnosis or late presentation. All the people that got picked up early because of the nature of our healthcare system, you have a nurse, you have a dedicated doctor, you have all of those people taking care of one person. If you look in the field or at the epicenter, those patients are seen maybe once in a day because you have one doctor seeing so many. So there is really no reason for anybody in the US to be alarmed about getting Ebola or dying from Ebola. We have the best public health system in the world.
Nancy, would you like to address that too from a business perspective?
Yeah, I wanted to compliment the city of Chicago, actually, in this regard, because when it was announced that there were 5 airports that would be subjected to enhanced TSA screening, the opportunity to present a controlled ingress to the U.S. from other countries that are affected, I thought was a really great opportunity for the healthcare community to designate hospitals in those 5 communities to basically coordinate and make sure that they have teams that are ready in order to deal with it. And Chicago definitely stepped up and did that last month, which I thought was excellent and a real testament to the ability to work together and recognize that doing it proactively, you're able to manage outcomes in a much more favorable environment.
I just want to add one other point to that, maybe just a little bit of the other side of the story. So along with all of our international work, we work domestically with a network of free clinics, free and charitable clinics across the country, all 50 states. And we actually run 4 clinics ourselves in the state of Connecticut. And as this was beginning to emerge back in the summer, our clinic director in Bridgeport, Connecticut, which serves a population of uninsured patients from poor communities there, which included a lot of immigrant populations from West Africa, we suddenly realized that at our own clinic there, the sophistication at a free charitable clinic that's run by volunteers is not what you're going to find at a big public hospital in the city. And this is true probably for this network of free clinics that we support across the country. So I think there are still vulnerabilities in our own health system here that this has raised some questions about that I think we need to pay attention to.
Nirav, did you have any comment on that with regard to regulation? No, okay,
I
great.
don't.
Thanks.
I don't know anything about that stuff.
Okay, thank you. Yes, please. The woman in the middle right there, please. With the glasses, thank you.
Hi, I do IT consulting, and especially I've been getting some certifications in big data, and I'm just wondering how we can utilize like all of the information that's coming in from Twitter feeds and Facebook where people are posting, I'm sick, I'm feeling unhealthy. How can we use that to then, fuel our responses to some of these types of global, events?
Anyone for that one? You mentioned Twitter, Shola, I think, at the beginning, and social media.
I do global health, and it's relevant both here and also here, because there are many rural communities that don't have access to critical care and all the sophisticated equipments that we have in the academic institutions. But increasingly, we're using technology to reach a lot of those places. And we certainly have an opportunity to use telephones and mobile telephones, which we're not using them as much as most people are outside this country. They're using it to monitor blood pressure, to monitor glucose. There are different apps that are being utilized to make healthcare accessible to a lot of people who are really almost off the grid. So we have a unique opportunity to use, social media effectively. In Nigeria, all of the telecom companies, they donated free time to be texting. Occasionally, we get the alerts about somebody who's been kidnapped. Why can't we use that to just inform people? But, there are privacy issues here. But in the setting of epidemic, they use that very effectively to educate. And I think it's a smart way to educate instead of just getting people very fearful of Ebola.
Okay, next question. Right here, please, in the middle.
Thank you very much. My question is about situational awareness. So we have an epidemic that's happening in Liberia, we have an epidemic in Guinea.
Could you speak into the microphone, please?
Oh, sorry.
Thank you.
My question is about situational awareness. How much do we know about the case counts? And how much do we know about what's actually happening in some of the rural areas of West Africa? You can look at, for example, at the CDC. So the CDC, in September, they published a study and where they claimed that the case counts could be underreported by a factor of 2.5. So what is now might be 7,000 cases in, say, Liberia could actually be much higher. So do we have surveillance systems in some of those rural areas? Do we have personnel that are reporting, or our data is basically localized to the big cities?
Michael, do you have any data on that from AmeriCares work there?
I don't have specific data beyond what you're referencing, but I will say this. Some of the news reports most recently out of Liberia about the case counts begin to slow down, and I worry about hearing so much about that because, for the exact reason that you're talking about, that I don't think the surveillance is good enough across the country to really understand yet whether the little brush fires of Ebola that may be happening all across the country and in the rural areas are well understood and well documented at this point. I had somebody ask me the other day whether it was time to pull back a little bit out of Liberia from the big efforts that's going on there to build Ebola treatment units. And I said, not yet. I mean, don't stop now. We don't really know for sure that the curve has bent enough in Liberia to pull back on that. Because I think this is an endemic problem in these countries anyway, is disease reporting.
I think you will have to assume that the number of cases are actually an underestimate. Because at the beginning there were many people in the rural communities that were dying. Nobody was there to actually count them, and people were not trusting of government. So I think it's fair to say that there's gross underreporting, but with behavior modification and the education getting through, because it's some of these places, the ritual around taking care of the dead, even burying them, those were really fanning the epidemic quite early, and I think the education piece might be getting through.
The missing negative case problem is omnipresent in epidemiology, but it's a problem that we know exists, and it's not as if we don't know whether there are 15,000 cases or 11 million cases, right? We understand the bounds of the issue, and our models can account for that. So we know what we don't know, and we have very good estimates for the magnitude of what it is that we don't know. So,
yeah,
it's
Judith.
not just the surveillance mechanisms within the country, it is the people within the country and within the regions where this might be happening, where they're not counted, and they're hiding their patients.
Yes.
They're hiding their loved ones because they see what happens when government comes in those suits that makes it look like a foreign alien has come into their midst, and then they never see their loved one again. So it's a similar situation to Southeast Asia when the avian influenza was running rampant in the poultry flocks. The people had their 5 chickens in the backyard, and they weren't going to tell the government when one of them died. They just weren't, because that was their food supply. So people are trying to act on their own best interest in many times, and this causes a reduction in the knowledge base that public health tries to put together.
Next question, right here in the middle of the front row, please.
I wonder if the panel could talk a little about the impact of branding on the U.S. perception of this disease. One is because the disease originates from Africa, a place where it has negative perception from a public health standpoint in the U.S. And secondly, because I would hypothesize that the name of the disease itself, Ebola, probably just sounds scarier than SARS or bird flu. So how much does that drive the public reception here in the U.S.?
Nirav, you want to tackle that one?
I'll offer one observation. I don't have a very good sense, to be perfectly frank. I don't know if Ebola is intrinsically scarier than SARS, which sounds pretty scary to me too. But here's my view. There's no question that the provenance of the disease makes a difference in how the fear response differs. And to the extent that we can do something about that, a gentleman earlier asked about what we can do to enhance our preparedness response. I agree with Shola. Our hospitals are pretty good. What's not great is our fear response. Our ability to communicate, to go back to what I said a second ago, our ability to communicate what it is we don't know is not great. And that's unfortunately by design. That's the way that epidemics work. You're always, as we used to say in Cambodia when I worked there, you're building the boat and sailing it at the same time. And that is a very difficult thing for public health planners to communicate to the public. So what should people do? Well, the Secretary of Public Health and the Director of Public Health of every state in the country should be out there giving talks to folks about what we know and what we don't know. The lack of confidence can be perceived as a lack of an ability to handle the situation, but a different approach, one that emphasizes what we do know and what we don't know, could go a long way, I think, to stymieing the fear that you mentioned at the beginning.
Yeah,
Go ahead.
I'm sorry. One thing I wanted to add to build on Nirav's comments. Judy, when she introduced me, she mentioned that I lead AON's approach to managing black swan events. And I just wanted to say, Ebola is not a black swan event, but there are impacts of black swan that I do want to kind of touch on briefly because it builds on your fear comment, right? So a black swan event, when we talk about it at Aon, it's really what might be a black swan to one person might not be to another who may have been through it before or who may have seen someone go through it before. When it's a black swan event for you, it's dealing with something that is bigger than you've recognized, bigger than you anticipated. And you have to mount your emergency response. You have to figure out what your underlying problem is and figure out a solution to that. And you have to do it in an environment where you've been shocked by being subjected to this kind of an event and series of following impacts that manifest themselves after that. And I've got a white paper, a copy of our white paper in the back, and you can also find it on our website. But it basically talks about what it feels like to be in an organization going through an event like that. So if you're going to talk about the Texas Presbyterian Hospital as an example, right? Here we are on our panel, we're talking about Ebola as a situation and as a disease. But you can also take it to a business and trying to deal with the business that's been impacted. And when you're going through that, you're trying to figure out what your problem is, how big it is, what it's extended to, what are the solutions. You're mounting your emergency response. You're trying to deal with the PR issues, and the PR isn't in a cycle anymore. It used to be you had news cycles that you could manage to. You can't really do that anymore. You also have to manage the news impact of social media and have thoughtful responses for that. You're being queried by governmental and regulatory authorities wanting to know what's going on, and that's oftentimes before you have your arms around how big it is. And being asked to comment on it when you don't necessarily have all the facts. So you start to see that there are a lot of things happening at the same time. It makes it very difficult to maintain a good decision-making environment. So when you look at organizations that manage through situations well and others who kind of struggle, what's fundamental is their ability to manage the decision-making environment. And there are some ways to do that that deal with the fear factor and deal with some of the other situations that can manifest themselves. So I encourage you to kind of take a look at that because it can be very helpful regardless. Because fundamentally, we spend a lot of time preparing for the things that we know can happen. But you can't really predict, is it going to be Ebola? Is it going to be MERS? Is it going to be SARS? You can't really always predict what it's going to be or when it's going to happen or how big it's going to be. But what you can prepare for is the impact. And if we can get better at managing the impact and understanding how the impact manifests itself, we can work together more effectively and deal with situations as they come up. So.
One other interesting effect of this particular situation that goes to a little bit to your question and some of your comments about the fear, I think, is that this has not turned out to be the kind of world emergency that causes private donors to donate a lot to the organizations like ours that respond. It's not like the Haiti earthquake or the Philippines typhoon or something like that. One of the reasons we're so grateful for the corporate support that we received is because I think corporations are thinking about it, but the general public is not thinking about it in that way. And AmeriCares and all the other agencies that are involved in this have not seen the outpouring from the general public with donations to support this kind of work. And I think somehow that's anchored in the same issue of fear or misunderstanding or it's far away in Africa or whatever. But it's been an interesting response that way.
And Michael, did it change once the Ebola came to America?
No, not at all. Not at all. In fact, I would say that that really took the attention off West Africa even further. And then when it felt like it was in control here, I think the general public just kind of forgot about it.
Okay, thanks. Bill Mahoney, please, in the front row.
I think a very basic question. I think the premise is that there is a global public health community, whether it's NGOs, international organizations, that are responsible for dealing with these type of issues. I would just be very curious to know from all of you, what do you think, how would you assess the global public health community response here? What is the most praiseworthy element about it that you think should be noted? And if there were weaknesses or flaws in the response, tell us what they were.
Great. Maybe we'll want to start with Shola and then just work our way around.
I think
Yeah.
probably the most noteworthy part of response to this epidemic is the willingness of nurses and doctors to put themselves at risk to go to those places to be part of taking care of the patients who are less privileged by being there. And it's actually very, very annoying when some of those healthcare practitioners get back and look at what we did to the North from Maine, just out of fear and ignorance. In terms of what's worked well, one has to, look at the NGOs, IMC, AmeriCares, and people who actually help coordinate the delivery of needed materials to the field. And when you look at the WHO, which is supposed to be responsible for monitoring all of this, when we have all these budget cuts and we cut down resources, WHO has been unable to actually do what they're supposed to be able to do in a timely and efficient manner. So when you look at it from the global perspective, business, economic, it doesn't make any sense in the new era where we live, where there are all the threats of all these epidemics, to keep cutting back on, the ability of the WHO to protect and curtail a lot of these epidemics. So from my perspective, I think those are the issues that I see in terms of where we can learn and do better.
Nirav?
I'll be brief. Put my cards on the table. I'm a skeptic and sometimes a critic of the broader global health community. I think with respect to the WHO, probably the best thing that can be said is that the meetings all ended on time, and that was great. Here's where I think they fell down on the job. They got utterly paralyzed when it came to choosing between two outcomes or two pathways that had resoundingly similar outcomes. And so there's all sorts of metaphors that can be used to describe that in the management literature. But to the gentleman's question, their fundamental problem was an inability to make decisions sooner rather than later, particularly when all the models and all the suggestions suggested that both pathways would have ended up at the exact same place.
Nancy?
I think Nirav and Shola said it very well.
Great. Michael, do you have anything to add there?
Just to echo your comment about the health workers, we actually recruited American doctors and nurses to go to Liberia, and it was interesting in conversations with them about that and their willingness to go. On the one hand, we didn't have a difficult time finding people who were willing to go. This is sort of the classic American spirit of compassion and action, right? They wanted to go and help. What they ran into were really three things in terms of being able to go. One was release from whatever their current assignment was. And interestingly, we have a whole public health system, and this is not where they were coming out of. These are people coming out of university settings, out of private practice, doctors who've done volunteer mission work around the world in the past. So getting out of their assignments, family concerns were second. And then their third biggest thing was, what's going to happen to me when I get home? How am I going to be received when I get home? Am I going to have to be quarantined for 21 days? If I volunteer for 8 weeks in Liberia, does that turn into 11 weeks? Because when I get back, I have to be quarantined in a tent somewhere. So these are the hurdles that we had to overcome in recruiting them. But they went anyway. There's an incredible group of really highly qualified people that are serving in those Ebola treatment units and in other places, and they really deserve our admiration. They're really heroes who rushed into that. To the points about the rest of the response, I think you're right that there are plenty of indecisions along the way and response. But this is one of those cases where it was a slow build. Things started slowly, grew little by little. And I don't think it got to the tipping point of people really pushing for action until it got a little bit too late. But it's easy to kind of look back on that, I think, now and be critical of it.
Judy?
Yes, I have just a little bit different perspective, and it's based on the legal view. And the legal view of this, the answer to this question is that after the SARS epidemic that circled the globe, there was a massive 2-year effort by the World Health Organization and the World Health Assembly, all 194 countries, to revise the international health regulations and to centralize the authority to act in Geneva at the World Health Organization. And that must be made known. Those international health regulations tell Margaret Chan exactly what to do in this situation. And what she did was something that was done very, very late and very, very, very much to the discouragement of everybody who was waiting for her to make the declaration of the public health emergency of international concern. The outbreak began in very, very late 2013, became known as and identified as Ebola in March. It took until August 8th for Margaret Chan to convene the emergency committee and to get their advice to actually declare a public health emergency of international concern. I will forever applaud the Council on Global Affairs for having used that phrase in the announcement of this program today, because it has not been appearing in any of the newspaper articles or any of the popular press that I have read. So I applaud you all. And everyone's looking to her, and why was it that she didn't? I do have one observation about that, and that is that she was so soundly criticized by the way she handled the swine flu pandemic, the first pandemic of the 21st century, and that might have been why she didn't convene the emergency committee. But budgetary constraints could not have been the answer for why she didn't convene that emergency committee early on.
Thank you. We have some students here from the Center for Global Health and the Harris School of Public Policy. Any questions from the students before we go back out to the general audience? Okay, great. The young woman right there, please.
Hi, first and foremost, thank you so much for being here with us today. And my question is, you mentioned that one of the possible solutions for disease control would be improving the healthcare system in say, under-resourced countries. And I guess I'm wondering, how do we do that at the right level of cultural competence?
Anyone?
We have a Nigerian healthcare expert. He seems like the right person to answer that question.
Actually, you know, McKinsey did a report for the Rockefeller Foundation in 2010, where they looked at how you could actually develop health systems in developing countries. And they used Ghana, they used Andhra Pradesh in India, they used Chile as an example, just looking at different levels. What they try to do, look, if you look at a lot of these developing countries, Nigeria included, people pay out of pocket for healthcare, okay? 80% of the funds for taking care of people, when people are sick, they find money to pay. It might run your family into poverty. Catastrophic illness usually does that. And what they've done successfully is to create a model where if you can actually get people to stop paying 80% and get them to 30%, they will be happy. And in Ghana, for example, they have the semblance of a primary healthcare system that extends all the way to the rural communities. But it's so basic, and what they did was they created a fund for that. They created value-added taxation. They made it a priority that they were going to develop a primary care health system. People paid into it, and that's ongoing. But the challenge is, once you have that primary care health system, how do you scale up to the secondary and to the tertiary level? The other example, which may be a little farther from sub-Saharan Africa, is what operates in Chile. Chile has a listing of the top 50 medical conditions that plague the Chileans. And they just align their budget to, okay, it is colon cancer. They put the resources in there. They have a fundamental decision that health is a right. Okay, so they created it, and people get primary prevention for dental care. You get dental care in Chile. You get obesity care. You get all of those things. Those are the kinds of horizontal investment that people can make that is sustainable. Otherwise, when we see all of these bad things on TV, just look at the cost of getting the U.S. military to go to Liberia to start building tents. For a fraction of that, you can actually, in partnership, start developing the semblance of an infrastructure in partnership. And over time, look at the case of Liberia. We have a personal experience from our Center for Global Health. For the past 5 years, our university, our students, and our emergency medicine faculty, in collaboration with colleagues from Harvard and University of Maryland, have been going to Liberia to help them develop their healthcare and medical school infrastructure. So a lot of the first-line healthcare providers that died in Liberia were people that we actually worked with. We pulled out of Liberia our students, our residents, and our faculty out of Liberia probably around April, 6 months ago. So there are many, many models where you can actually get people to come here. We train them, they go back, and then we start building capacity in partnership so that we don't have to send our doctors and to send all our nurses there. And the flip side of that is the brain drain, because people who graduate from nursing school and medical school in Liberia, in Nigeria, in Ghana, in sub-Saharan Africa, everybody wants to come here. And if you look at all the international medical graduates here, and you look at where they're coming from, 60% of them are coming from, places in sub-Saharan Africa where they don't actually have enough doctors there. I know in the interest of freedom, people should be able to do what they want to do. But it's quite complicated, but where there's an opportunity to invest smartly, I think we could do it.
Okay, we have time for one more very brief question, please. The lady right there, please, to your left.
I was surprised when the young lady said that Ebola is not a black swan event. I'm wondering if you could defend that from the point of view of the government or the people of Liberia or Guinea or Sierra Leone. Sorry.
Sure.
It seemed to me that it's not a black swan event here. But
thank you.
No, I think that's a good question, and the kind of goes to my comment about what might be a black swan to one person or one country might not necessarily be a black swan to another. If they've been through it before, or if they have seen someone go through it and have been partnering with them and understanding what they needed to do in order to address it. So certainly in the countries that have been impacted by it, I should say that one of the challenges of black swan is it's a problem that's so large or so complex that you don't really have a good answer. It's not that you can pull a solution off the shelf and implement it. You have to figure out how you can put pieces of solutions together in order to make an impact. And the challenge in doing that is when you've got a problem, you don't have a solution. You don't know what your outcome is going to be. You don't know how you're actually going to get there. That's very difficult to make good decisions in that environment. That fear factor of having a problem with no known solution or no certain solution is going to get you there. So the comment about a black swan event, it's just dealing with the recognition that in that type of environment where you're trying to deal with that shock of finding out that you've got this situation, you don't necessarily have a ready solution, you don't know exactly how you're going to get there or how fast you're going to get there, and still maintaining a good decision-making environment in that regard. So certainly, like I said, it was a black swan for Texas Presbyterian Hospital. It's a black swan for the community that's going through it. But for others, it might not necessarily be one, but it's something that everyone can learn from. But the challenge in maintaining a good decision-making environment and understanding what goes into that, it's a real opportunity for people personally as well as organizations.
One last point on that. It's interesting, if you look at those three countries in particular, Ebola may turn out to be not really the biggest thing happening there during this last period. It certainly is the cause of something else, but that is, we haven't seen yet the statistics on the number of deaths from childbirth, from malaria, from other tropical diseases, just the ongoing problems that they have that are not being addressed because the health system is shut down there, because people won't come to the clinics, they won't come to the hospitals because of that. And my guess is, when this is all said and done, that we're going to see that there were more deaths from those sorts of things during this time frame than from Ebola itself. So this is a really big deal for these three countries, a really big deal. And I don't think we here can really understand the scale and the scope of it.
Ladies and gentlemen, please join me in thanking Nancy, Nirav, Judy, Shola, and Michael for their comments tonight. Oh, and also Jeff and Abby.
I just want to say how lucky you all are to have this great resource here with the Chicago Council. I mean, you're so fortunate. I always feel a little sad that we're headquartered 2 hours north of Chicago, because I would be here almost every day to these sessions. I actually get more work done, I guess, being up there. But I just want to say a special thanks to Neve and Anna and Nick and all the staff people that make these programs happen. And we're so proud to be connected with you. Thank you so much.
Thanks, Jeff. Also, thanks to Chicago Council on Science and Technology and AmeriCares.